Yeah, good evening. Today we're going to discuss about, last time many, students want to know about the mechanical ventilation with respect to sepsis, as well as, how to manage the ventilator settings when there is especially metabolic acidosis is there. Dr. Sundaram actually managed one case in Chennai. I think Sundaram is not there. I think I will just go through the details, and in between also I'll try to discuss about the case, how he managed, and how would have been managed in a better way. That's the main discussion. I want you two people to be interactive so that you can any point you want to discuss highlight. I'm very happy to discuss that part. So July 31st and in August 1st, midnight, okay? 50-year-old female, 60 kg. Why he didn't mention about the weight? So I purposefully mentioned the weight of the patient. Why in any mechanical ventilator patients, you should know the weight. Which weight? There are two types of weight. One is whole weight, whole body weight. Another one is ideal body weight. Always try to calculate the ideal body weight when you want to ventilate any patient. Okay, that is very important. Ideal body weight, how do you calculate? You have a lot of formulas in the Google, you can select one, okay, and use it. It depends on the height of the patient. I think Sundaram is there. Dr. Sundaram, okay. Sundaram, just I am narrating the same, case study. Are you able to hear me? Okay. So, weight, ideal body weight is very important. That's why I mentioned the weight of the patient here to know the difference between ideal body weight and whole body weight. Patient is, known case of chronic mild liver and kidney disease. So there is a pre-existing liver problem and kidney problem is there. It's a very important. When you want to manage any patient, try to make sure that some part is a past history which will be contributes to our further progress of the disease. Okay, it may is a kidney disease is already having she is having already having pre-existing kidney disease means whatever if there is hemolytic instability is there, or if you want to use any nephrotoxic drugs, okay, that can worsen the kidney problem. And once the any patient, especially infection patient, going for kidney problem, there is a mortality increase from 60%, increase 60%. That's the importance of kidney disease. And even liver is very important because we have to use many drug modification while managing this patient. That is very interestingly, he's mentioned chronic liver and kidney disease. So I mentioned that point also. So we'll go to the actual case actually here, acute obstructed umbilical hernia. So presented midnight in July 31st for emergency laparotomy. I think is Sundaram able to manage anesthesia and critical care. I think so. Is it right, Dr. Sundaram? Okay, I think you are not audible. You can, you are not. Am I audible? Am I audible, right? Sundaram, you are not audible.
Yes, sir, you're very audible, sir. Very clear.
Okay, see, what he has done surgery, not able to extubate after surgery. This is a very important point here because of the major surgery. So he has mentioned the abdominal surgery with medical illness with AB showing acidosis. These are the few points. Each and every point is important here. See, whenever you are operating on abdominal surgery, okay, you have to think of there is something entity called type 3 respiratory failure. So this is a very important. Type 1 you all know hypoxia causing respiratory failure. Type 2 also you know hypercarbia causing respiratory failure. But type 3 because of the you know especially post-op patient there is a major surgery, there is a large incision is there. So what happened because of the pain and splinting action of the abdominal muscles, even respiratory muscles, the FRC will goes down drastically. So he is not able to maintain the alveolar ventilation. So actually what I am talking is, because of the abdominal surgery, because of splinting action, patient is not able to breathe properly as used to breathe before surgery. So that causes type 3 respiratory failure. That is very important. You have to be aware about this. And AB is showing metabolic acidosis. This is what I am concerned here. When there is ABG having acidosis, first of all, we should not wean this patient. So when you will wean, this is a patient not extubated, good decision for major surgery. But from my point of view, even you should not think of weaning here, not even extubation. That is the major point here. So the question here is, why acidotic matters. This is the last time also you people are asking how to manage metabolic acidosis. I think Sundaram also asked the same question. Just I mentioned like tachycardia 120, same patient, BP 90 by 60, little bit requiring fluid response. You are giving fluids there. Respirated 30 because of the metabolic acidosis. You want to hyperventilate. SATs are okay, 99 with 5 liters oxygen, because here he is intubated. Sorry, intubated acidotic breathing. In this patient, which I'm concerned of, is not intubating, not intubated. I'm telling how to intubate and ventilate this patient. So what is I mean to say is, before intubation, you should know the plan of ventilation this patient. And there is a metabolic acidosis there. That's a very important point. We all think of ventilation after intubation. No, that's the wrong thing. Before intubation, while intubating or putting tube, that time you have to think of how acidosis matters here. ABG is lactic acidosis. Dr. Sundaram case also showing lot of lactic acidosis. They'll show that ABG. Look at this ABG. Can anybody want to read this ABG? If anybody volunteer, okay. See, look at the first point. If you want, I can even discuss about ABC later in any class also. ABC, knowing ABC, you can manage any patient easily. You can manage any patient. pH is 7.23, means it is less than 7.40, means it is a acidosis. When there is acidosis there, you have to look for the carbon dioxide, increased carbon dioxide, because in carbon dioxide is acid. Increased carbon dioxide can cause acidosis, that can cause respiratory acidosis. In this case, there is no increased carbon dioxide. And look at the bicarbonate, reduced bicarbonate, that will contribute to metabolic acidosis. So there is a reduced, it is normally 24, it is 14. So the reduced bicarbonate showing that there is a metabolic acidosis. So it is a case of metabolic acidosis. So very easily we can see this. Whenever such patients is there, always any critical kill patient, emergency patient, think of always ABC. Try to manage first A, then B for breathing, A for airway, B for breathing, C for circulation. Always go with the, even though you complete C calculation, again come back to A, whether you are able to manage A or not. These are very important. Always think in this direction, A, B, C approach. Okay. So here what is happening? Metabolic, here I mentioned again less than 7.35 pH. So acidemia, bicarbonate is less than 22, because plus or minus will take for bicarb 24. It is a metabolic acidemia. So you should know, if there is a metabolic acidemia is there, what should be the carbon dioxide values. So we have to use the Winter's formula here. Always have Winter's formula in your, within second you should be able to calculate. That's the experience. So you have to see thousands of ABG to manage clinically. Write ABG, calculate. So here 1.5 times the bicarb plus 8 plus or minus 2 is the Winter formula. Bicarb is 14. If you calculate here, it becomes 29 plus or minus 2. So expected BCO2 should be 27 to 31. What is the carbon dioxide here? 34. What it means? So anybody can tell what it means? There is an expected carbon dioxide according to Winter formula. For this bicarbonate, we should expect PCO2 at least less than 31, 27 to 31. But it is 34, means that patient
Hypercapnia, sir.
Patient is hypoventilating. Actually, we expected to be hyperventilation, but he is hypoventilating. That is a very important point. Remember this. Why I need this is, if bicarb is PCO2 34, so while intubating this patient, you have to hyperventilate with AMBU. While we are giving induction drug, like if you use ketamine or whatever you comfortable, use induction drug, use hyperventilate. How much rate? At least 2 times the 2 times the regular minute ventilation we can say. I'll come to that calculation here. So whenever metabolic acidosis is there, always calculate anion gap. So in this case, there is metabolic acidosis and respiratory, because PCO retention is there, we call it as respiratory acidosis. Check anion gap. Always look into anion gap. Sodium in this is 130, chloride is 100, 130 chloride plus bicarbonate. Sodium minus chloride plus bicarbonate is the formula. 130 minus 114 is 16. High anion gap metabolic acidosis. So when there is a high, even though it is not related to Sundaram patient, but I want even Dr. Sundaram to go through the same case retrospectively, think what can be done for this patient. So only I am highlighting these points. Very important points. Very important points. Every day you have to manage. So if there is a metabolic acidosis with high anion gap is there, always think four causes. One is lactic acidosis because of sepsis or hypoperfusion. Second one is renal acidosis. Look at the kidney renal acidosis. Okay, you the blood urea interatin. Look at urea. I'm sorry. What sugar? Sugar. Look at the high blood sugar.
DK, sir.
Yeah, and
It's
look
written
at urine ketones. DKA. If nothing is there, think of poisoning. It is in the last option. Why I'm telling this? In case lactic acidosis is there, your treatment will be giving fluids, maintaining perfusion. If you are not able to, if you are not giving fluids in this patient, as Sundaram patient, there is a metabolic acidosis was there. If you are not able to manage acidosis, hypoperfusion related acidosis, you will fail in extubation. You will fail in weaning. If there is renal acidosis is there, then again he able to do hemodialysis later part of the progress of the disease. If creatinine is high, even I insist on go for early hemodialysis. How early depends on each patient. It comes with practice. With early means it is not the actual number of blood urea or creatinine. It is the how much kidney is contributing for your acidosis and causing problem. That's how early. I'll discuss this part
Sir,
again.
in
Okay.
sir, in this case, if like creatinine and the urea is high and patient is hemodynamically unstable, and we know there is AKI, acute kidney injury, or there
Okay.
is renal failure, in that case, if we are proceeding towards, as you says, we should do hemodialysis and patient is not suitable, then what we should do?
No, no, you should not go for. That's what I'm telling. If there is, I'll show this ABG. There is a bike. I think lactate is 30. I think when there is a high metabolic acidosis because of lactic acidosis, that is causing hyperperfusion. That is causing hyperperfusion to the kidney. Then priority is giving maintaining hemodynamic stability. Give fluids. Look at the IVC contractility index. You can see. I'll tell you how to give fluids
Mm-hmm.
also. Look at RARV
Mm-hmm.
dilatation. If with the echo, always use echo. Echo is your bedside stethoscope. Okay.
Mm-hmm.
Use echo, RRV dilatation, IVC. If nothing is there, even ultrasound lung also. Try to learn ultrasound lung. Now ultrasound is available. I will discuss that part later. But try to correct fluids and hemodynamic stability before going for. It is a very early stage. I'm telling. So don't go for
Mm-hmm.
dialysis now. Maintain fluids, hemodynamic stability. If decay is there, give a lot of fluids and start insulin. So what I'm telling is, without correcting the acidosis, you cannot able to manage this patient. That is the main point here. Okay, I think you're getting this point. While you're
Mm-hmm.
doing intubation, I want you people to hyperventilate. Make sure how much hyperventilation patient required. Okay, if the patient require higher minute ventilation, try to maintain with the higher minute ventilation. Higher ambling, higher rate will manage the patient. Some patient people will know bicarb will be 10 will be there, PCO already 40, 45 will be there. If you ventilate it 10 to 12, during intubation only patient will arrest. Many times it happens. Then they don't know,
Yes.
I didn't know sir what happened. Patient is arrested while intubation. That is because patient want to wash out carbon dioxide to maintain pH. But you are reduced minute ventilation and is retaining carbon dioxide. pH is dropping to 7.00 or 6.95 and there is a cardiac arrest. This is a very common scenario. So I want to plan the
Yes,
patient
yes,
case.
sir. You are very right. In such a patients, like when we take for emergency laparotomy and patient BPs are like dropping, we when once we give propofol, even ketamine, you will see drastic fall in mean blood pressure.
Yeah, never touch by propofol. So when
Yeah, I'm just giving an example. Like it
yeah,
happens with
correct.
me
Good idea.
initially.
Good what you told. What I'm telling, use ketamine or etomidate. Okay, you can use ketamine.
Mhm.
Ketamine is the best, cheaply available. You can use ketamine. Don't worry about
Yes, ketamine is readily
causing
available.
all
Mhm.
ICP, ICP increasing, intraocular pressure increasing. That is all practically negligible. Actually, don't worry about that. So drugs, I'm telling again, this is the point here. Select the drugs appropriately. I think you are all anesthesiologists. You are better people to take care of those drugs. But be aware of that. This drugs causing vasodilatation. Even
Mhm.
even your fentanyl, midazolam, all of those cause vasodilatation. BP drops while intubating these patients. So here I am telling ventilation SATS 99 with 5 liters oxygen dose breathe, same patient. I want to ventilate this patient with high ventilation. How much? The most of the time it will be 10 to 20, 12 liters per minute. So usually 5 to 6 liters is there. We till regular minute ventilation, double it usually, that will work out. Why? How I got this value is, so you can see, look at the look at the minute ventilation rate is equal to the weight minute ventilation divided by tidal volume. Here I'm selected tidal volume like a 480 ml. I want what is the rate, actually you can calculate, even you can calculate. However, if you want minute ventilation of 12 liters divided by 480 tidal volume, that amount of rate you have to keep 25. This is how you
Mhm.
have to select the initial respiratory rate while ventilating this patient, especially there is metabolic acidosis. You remember this? It is simple formula. Minute ventilation is tidal volume into rate. You want minute ventilation on 10 to 12 liters. You know the tidal volume for that patient like 400, 450, 500. So minute ventilation by tidal volume will give the appropriate and take ABC and adjust the rate. That's how you have to manage. You have to remember the mode. Mode, many people asking for the which mode, either volume control, pressure control, that nothing matters. I told you very clearly, it is how you set the ventilator, how do you manage, that is more important. If you use a volume control, manage pressures. If you put pressure control mode, manage volume. That's it. Nothing else is there. That is the crux of the modes, nothing much. You can discuss later also when if you have doubt. So coming to this case, August 2, second day, they luckily they are not extubated this patient. I don't want you people to wean this patient during metabolic acidosis. Make sure that you can correct that acidosis part. Sedated, not paralyzed, could not win because metabolism. Again, could not try win. Why? What happens if you win? So why we want to put the patient on mechanic ventilation? One is to maintain oxygenation. One is to maintain ventilation. Third important criteria is indication is to reduce work of breathing. So you remember this. If the patient normal, you and me, what is the oxygen requirement for the respiratory muscles? Do you have any time you have thought about this? It is only 3 to 5% of the whole cardiac output or whole oxygen content of the body. Only 3%. Imagine the patient comes with respiratory distress, that same patient requires 30 to 50% of the oxygen supply to the respiratory muscles. So what heart will get oxygen? Heart will go for hypoperfusion, then you see ST depression in your heart, ECG, patient heart. And if you patient will become restless because of everything oxygen you are giving for the respiratory muscle, brain will get less oxygen, patient will be irritable. Sundaram mentioned there is a delirious is there. I want you to manage this delirious. Have you appropriately managed the respiratory muscles workload? It's a very no books mention this, but at the bedside, I want you people to manage this. Work of breathing is the most important thing in managed patient. If somebody can mute, if anybody, you know. Okay, good. So look at this point, very important point. Always think of why you're intubating, ventilating, oxygenation, ventilation. Another one is reduce work of breathing. So make sure that work of breathing is not increased. So good thing you are sedating. But when the acidosis is there, respiratory muscles are working more. Good thing you are sedating, even you can paralyze. But sedation paralysis, I want you to highlight one more point here. Don't use sedation paralysis more than 48 hours. Even in ARDS, don't use paralysis more than 48 hours. You can use only for 24 hours paralytic agents. More and more paralytic agents if you use, there is a neuromuscular blockade in worsening that cause fatigue of the neuromuscular block. I mean to say neuromuscular neuropathy. That is called critical illness polyneuropathy or CIPN. Very important entity. Widely means it is the most neglected part actually. critical illness for any patient with sepsis more than 5 days, 7 days, 99% will have myopathy or neuropathy. Please remember this, 99% I'm telling, not a 1%, 2%. Any person sepsis more than 7 days, 100% will have neuropathy. How the sepsis acts on the kidney, causing kidney injury, you have mentioned kidney injury, liver injury, same it happens even the brain, nerves and muscles. So, but we will not, muscles and nerves also the organs, many people will neglect it. So when you want to take care of the kidney, take care of the muscles also. How to take care of muscles? Avoid mineralizing agent, avoid, you know, um, myotoxic drugs, neurotoxic drugs like aminoglycosides. I can say aminoglycoside best drugs can be used, but use when there is necessity. Try to avoid those or avoid muscle relax. Steroids. Steroids another one causes the problem. It is not actually steroid. It is the illness plus steroids and neuromuscular blockade, all factors causes the neuromuscular neuropathy. Sundaram rightly mentioned because the neuromuscular weakness, he mentioned twice or thrice in his. So I want to mention that do not use relaxant not more than 48 hours. You can sedate. Which sedation you want to use? That is the most important. Sedation many people use, midazolam quite commonly used, but benzodiazepines, longer usage, especially renal failure, especially liver failure, causes delirium. So delirium is the, again in this case he mentioned delirium. Delirium is an important aspect, even it indicates mortality also. Take care of delirium. Delirium means it may be hypodelirium or hyperdelirium. Patient be restless, irritable, or it may be hyperdelirium, just will be calm, quiet, not speaking. Two types of delirium. Hypodelirium is most dangerous. Hyperdelirium is most of the time, better option called the hypodelirium. So remember this sedation. I actually choice is what you call dextromethorphan, but how many of you are affordable for dextromethorphan? Very less affordability will be there. If you have the option, if there is no bradycardia, no hypertension, use dextromethorphan straight away. No use. Don't worry about 48, 70 hours. You can use easily. You cannot use for longer time. But if you don't have, you can use fentanyl as analgesia, midazolam as a sedatives. You can use it, but reduce the dose. How to reduce the dose? Early morning, come and stop the drug. That is the best way. That is called wake up call. Give wake up call for every patient in your ICU. Morning 6 or 7 o'clock, 8 o'clock, when you before you are coming, or when you come afterwards, you can stop the sedation. See that patient is becoming awake or not. If the patient is awake, means that patient, whatever the dose we are giving, it is right. Or you can go for sedation scoring system. Always tick the sedation scoring system in your ICU. Tick 2 or 3 scoring system. So many scoring system is there. Adopt one scoring system. You can go for grading of 2 or 3. So that's how we can manage sedation. Don't over sedate. Nowadays there are a lot of articles have come. Over sedation causes longer ventilator period, infection risk, and death. That is the problem. So could not wean because of metabolic acidosis. This I have answered already. Here, when to wean. This is the important slide actually. When to wean. Never try to wean early. If you wean early, workup breathing increases. So you're actually harming the patient. More and more muscle usage, delay in weaning will be there. So prolonged weaning will be there. Do not go for early weaning. Do not delay the weaning also. If you delay the weaning also, there is a neuromuscular problem will be there. Appropriate when to wean. Evidence of some reverse of underlying pathology means whatever you are intubate. If you intubate for the pneumonia, make sure pneumonia is clearing. If you intubate for the respiratory problem, make sure the respiratory problem is clearing. Here in this case, surgery related hypoperfusion, kidney, liver settling down or not. If those things are settling down, then we can try weaning. Look at the reversal okay or not. Look at the oxygenation is okay or not. PO to FiO2 ratio more than 150 or 200. Look at low FiO2 and low PEEP. 40% FiO2, 40% take it, and PEEP of even 5.8 is enough to go for weaning. So some reversibility should be there. Underlying disease for which you are intubated. Some oxygenation should be good with the less FiO2, less PEEP. Patient should be stable. Stable means hemodynamic stability. If you require small dose of adrenaline, small dose of noradrenaline is okay. Patient should not require 2 or 3 vasopressor, then you start weaning. Never do that. Whenever patient is having larger dose of vasopressor, don't ever try to wean. That weaning will fail because hemodynamic stability is the one of the major criteria. Why it is important? See, you are optimizing hemodynamics and try to maintain the perfusion. Ultimately, you are giving oxygen delivery only. Actually, you are working, increase the work of breathing again. And to capability to initiate inspiratory effort, this is very important. If the patient is able to try to trigger, if you want to extubate, you should have trigger. If there is no trigger, then go for directly what you call tracheostomy. So in August 2, I think Sundaram, okay, I think, okay, I myself explain. He is sedated and not, again, could not, same thing. August 3, again, was sedated, not paralyzed. Try to taper sedation, assess the GCS, poor orientation. I told about delirium. Delirium, look at the delirium. Delirium, the most common cause is sedatives and in what you call immobility and not involving the attenders, not knowing the timing actually, either day or night. Delirium, you can read about those. Delirium is important point. With a smaller intervention, we can recover, make sure it is appropriate. Poor respiratory of August 4. So said with midazolam for disorientation. Again, I told the patient going for delirium here. Delirium may be because of reduced oxygen supply to the brain, or no, irritability because of reduced oxygen supply to the brain, or it may be because of the delirium per se. Okay, August 5, hemodialysis done. Good thing. I think there was a kidney has worsened here. So has undergone hemodialysis, liver function improved. GCS orientation is better. Poor neuromuscular effort. See again. So this poor neuromuscular efforts. So what you have to do is try to mobilize that patient to chair as as early as possible. The moment you mobilize to the chair, or make, always try to keep the patient in proper position, 45-degree. Make sure that diaphragm is lower and respiratory muscles in the vertical position as much as possible, so that is a natural way patient can breathe. In supine position, you have to breathe, you have to use more work of breathing. Positioning matters a lot here. So poor neuromuscular efforts, how to manage? I'm telling, mobilize the patient to chair. Even though patient on ventilator with the tube, try to keep the patient on the chair. Okay, that is very important. Even in the patient bed, keep in propped up position 45-degree. Any patient, if there is no contraindication like a spine pathology or hemodynamic instability is not there, immediately make him propped up position 40-45-degree. Make sure that position is appropriate for weaning. Okay. Mechanical continue decreasing sedation. They tried weaning on August 5. 6th August 6th, they tried, sedation stopped, SIME VC mode. Any mode you can use. You can use either directly assist control, volume control mode, assist control, pressure control mode, SIME volume control mode. But I want to tell that don't use SIME mode for weaning per se. It's a very bad choice. A lot of evidence is there. I'll tell that part if time persists. If you are interested, I will tell that evidence also. Never use SIME volume control or pressure control for weaning point of view. As a primary, you can use it. Means as a first mode, you can use it. While weaning, you can go for either CPAP pressure support. I think they have tried CPAP pressure support here. They have mentioned here. FiO2 to 50, saturation 90, RFT, LFT better, sensorium better. Respiratory could not be. Respiratory efforts are not there. I think so. That not tried. They tried CPAP pressure, not able to try. So again, I'm telling this patient, respiratory effort means neuromuscular weakness. Make sure drugs is appropriate, early mobility, avoid sedation longer period. A phase comes where patient without delirium and without sedation get readiness for weaning. Okay, so I think they try to wean. Post-op 5-7, we noticed on and off patient required increased FiO2. Why it is so? He was completely, saturation was requiring 70, then again requirement was reduced to 40. Why it is happening? Anybody guess here? Why it is happening? Saturation requirement is going up and down. This I'm very happy to answer here. If anybody guess,
Sir, because of this neuromuscular fatigability which the patient is already having, is it not?
saturation requirement, okay, yeah, neuromuscular ability requiring more oxygen requirement, that can demand is supply is less, your FiO2 is less, so that saturation, maybe that is right. But I will tell another answer. Pressure from operating surgeon, either exchange the tube and tracheostomy. This I want to answer here itself. Never change the tube if there is no block. So continuity in the system matters. tube, circuit, okay, connected ventilator matters. If more and more you disconnect for suctioning also, risk of infection increases. Use closed suction.
But sir, here we can see that the patient already is on the same ET tube for at least
No,
5 to 7 days in the.
no, never try. Routine change of
Okay.
tubes is not indicated, not recommended. Why it is so? Breaking the closed system increases the complications, including infection. Okay, here
Mhm.
changing tube, aspiration, infection, most common cause. If there is no tube block, don't change it, irrespective of who are telling. Even Foley's catheter, even central line. See, what you have to see is
Mhm.
whether tube is required or not. Any foreign body is not required, remove it straight away. That is the first point. If the if the endotracheal tube, Foley's catheter, central line is not required, remove it. Don't worry. If it is required, you should know when to change it. Changing routine change 6th day, 7th day is not recommended. Very clear message I'm giving. There is no confusion here. Don't do that. That is very bad practice. So always remember closed system, never break the closed system. That is very important. Tracheostomy will discuss that. Physician dilemma whether we go ahead with the extubation, I'll tell this, or go with the tracheostomy. Anesthesiologist, in spite of good tolerance on TPs, did not get feel that patient would tolerate extubation because of fluctuating neuromuscular effort. So they tried TPs on and off,
Yes.
but not possible. So this is the thing. In this ABG, you can see here. I think it is a seventh day. I mean seventh day. I think 7.07 when they are trying to wean 7.0. There is acidosis is there. Look at this
Sir,
7.
how much it is? 7.07.
Yeah. 7.00, there is a metabolic acidosis is there. Look at the bicarb. Bicarb, always take the actual bicarb. Don't take standard bicarb. Okay, don't take standard bicarb. Bicarb is, I think, 12 here.
17. Okay,
17,
12.
17. Okay, 17.
Yeah.
Bicarb is
Yeah.
17. So metabolic acidosis is there. This part, again, I'll discuss if time permits. What I want to know is, I want to tell you, uh, I'll come with the I will come with the this one weaning. Just few points I will want to add now. Okay, go through this weaning. Weaning means ventral discontinuation. Okay, extubation means removal of tube. There are two different things. Okay, so this you have to make sure the balance is okay. If the requirement of ventilation, if there is a risk of ventricular lung injury, pneumonia risk is there, airway trauma is there, we'll try to wean early. If there is a premature extubation or wean can cause muscle fatigue and cause more problem. This also cause more problem. Early weaning, early extubation can cause muscle fatigue and gas suction failure and reintubation. Reintubation, I want to give a clear message in this case. What is weaning? You all know there is a reduction of the level of the support. This is the when to start weaning. I discussed already when to start weaning. I brush through this case, this theory part. I want to concentrate more on practical part here. So when to start weaning, I told 4 points criteria should be met before weaning. Okay, if the fourth criteria is not there, don't worry. 3 criteria should be met. So weaning trial is called spontaneous breathing trial. Remember this SBT. How many of you know SBT? How many of you know SBT? Spontaneous breathing
No,
trial.
sir.
So
Yes.
you don't know this,
TP.
can't wean patient. So that is the importance of spontaneous breathing trial. What is important? I'm going to tell you. See, earlier what used to do while weaning, they used to do a lot of parameters, like a rapid shallow breathing index, minute ventilation index, crop index, so many, n number of indexes came. So no indices works actually at the bedside. Then what to see? What we are doing, we once the patient is fit for weaning, how we know fit for weaning? Make sure the underlying pathology is recovering, make sure hemodynamic stability is there, saturation requirement is less, PEEP is less, then start weaning. How to wean? Put on spontaneous breathing trial. What is this trial? We are straight away reducing the level of the support drastically to low level, either TP's trial or CPAP with pressure support trial for brief period, 30 minutes, not more than 2 hours, and see what happens. If the patient is having tachypnea while SBT trial, If the patient desaturation during SBT trial, the BP increases, patient become delirious, patient become irritable, restless. That is a SBT failure. Don't try SBT again. Put back on volume control, full support, and try to see what is the cause for SBT fail. This is the ideal way of weaning. Okay, this is a standard of care. So how to you put on TPs? Yes, you can put on TPs directly, but usually we try evidence of CPAP with pressure support is better option than TPs. Why? Because we are giving endotracheal, there is some resistance is there. We want to reduce that resistance, and we want to open the walls of the inspiratory wall. So he need more energy for that. Give with CPAP and pressure support. That is the best option. Newer recommendation mention CPAP pressure support. Go with CPAP pressure support like a pressure support of 10 or 8, even PEEP of 5 or 6, and try to see what happens to the patient. Patient go for tachypnea, tachycardia, desaturation, immune instability, or he can tolerate very well. If he is tolerating well, means he don't want ventilator only. Try to wean him extubate early. That's it. So SIME was the weaning trial earlier, but nowadays contraindicated. I can say directly it's contraindicated. These are the three, which is the better. So many trials have come with this. This is the brochure trial. He is the one. Esteban and Brochure are the two people. When they compare TPs and press support, they found that TP, CPAP, press support both are equally okay. And now newer recommendation mentioned that CPAP patient slightly better than TPs. You can use both. How I use CPAP press support regularly use if you have a neuromuscular blockade, then try to think of like a OP poisoning, like a myasthenia gravis, like a GB syndrome, then try to go for TPs trial there. That is the best option we can see, but both are equivalent. So then 2 minutes, 2 hours trial is too long. Earlier weaning was done 24 hours. If you could 8 p.m., they used to come at 4 p.m. No, weaning failed. No, not like that. Why it is matters there? Why only 2 hours? Why 30 minutes? Now studies have come up to 30 minutes enough, not even 2 hours also. Earlier we used to do 2 hours. Now it is 30 minutes. Why it is important? So it is like a, if you want to know the heart is okay or not, what you do, that patient, you make him walk in the treadmill. You make him run in the treadmill, see that tachycardia patient can tolerate or not, any get rhythm changes there or not. So it is a treadmill test for the patient on ventilator. So actually the treadmill test, we call it as treadmill test. If the patient put on that test, if he is able to manage for 30 minutes, he can easily extubate. Chance of extubation failure is very less. If he not able to tolerate means he need more support. Don't wean him. Put back on volume support because uh, you know this is called early weaning. We call it as premature weaning. Premature weaning. So 2 hours or 30 minutes both are same. You can try both. I try only 30 minutes. If that is not there, go back to ventilator. See why he is not able to wean this patient. This patient why I am not able to wean. I'll tell you later. Intermittent NSIME also they tried. They found that SIME was not a very good option. I think that slide is not there here. Same Esteban and brochure trial they have mentioned that recommendation 30 minutes to 120. This is the so many weaning parameters they have come with tidal volume, max VV, vital capacity, negative inspirator pressure, workup breathing, pressure time index. You can mention RSBI, crop. Don't worry about those things to know the whether it can tolerate weaning or not. So what I want you people to try, see so many points are there here. If minute ventilation 20 minute patient 10 to 15 liters we can wean him, negative inspiration minus 20 minus we can wean him, so many are there. But what we do is weaning we can put on SBT. This is the RSBI, which RSBI here rate is 25, tidal 250. He passed the test, means it is a tidal rate divided by tidal volume in liters. It should be less than 100. If it is more than 100, it should fail test. Nowadays we won't use this. Go directly with the SBT trial, spontaneous breathing trial. It will not predict the weaning failure. See, any beginner can tell that yes, this patient can be weaned and extubate. Any nursing, even nurse can tell it can be patient is tolerating very easily, sir. Weaning, you can extubate him. But who will tell the weaning failure? So RSBA will not tell weaning failure. Weaning success anybody can tell. Don't worry about that. So tools are there. I told about SBT. I don't want to mention this. If failed initial trial, in the Sundaram, Dr. Sundaram was mentioning repeated tried and failed. This is the cause, important point here. Failed weaning, okay, failed weaning. Then there are they even they failed weaning. They try TPs or SIME. SIME, how they wean? They reduce the rate from 20 to 18, 18 to 16, 16 to 14, 14 to 20, 10, 10 to 6, reducing the rate and converting to CPAP or support like that. They used to try that. That doesn't work out. I think the Spanish trial they found that SIM is a very bad weaning trial. Okay, don't use this. Use the CPAP press support first option. I can go for TP's trial. Again, I told 30 minutes. IME is not a good option. Benefits, you can use the protocols. I told no weaning protocols. Early morning stop sedation, that is called wake up call. Make sure sedation is given less, and weaning protocols are there. You can teach staff, okay, put on CPAP pressure support 14 and 8, reduce pressure support gradually till pressure support 10 and 8 or 10 and PEEP of 6. Then see whether the 30 minutes SPT will tolerate or not. If you tell staff, she herself will tell, she'll put on CPAP pressure support of 14 and 6, gradually reduce CPAP, and at 1 minute, in one moment, 30 minutes, they'll do SBT trial, low pressure support, and see whether the patient tolerates or not. Protocol is the key in weaning, sedation and all. So here I'm telling extubation failure, what happens here. I think some of the doctors or physicians were pressurizing, an intensivist, Dr. Sundaram, to extubate or go for tracheostomy and all. So this is a very important point, and you also mentioned about NABH. If you extubate, such patient will. I think I'll take that word. Exactly what you have mentioned. I will mention that very beautifully. You mentioned that. Let us pull out the tube and see what it happened. That is not going to work out in your ICU. Extubation failure can cause mortality. Extubation, that is called reintubation. Extubation failure means you are going to reintubate within 24 hours. That within 24 to 48 hours, that causes mortality. What is the percentage of mortality? 15%. Significant in your ICU. So extubation failure can happen because of airway edema, also because of laryngeal edema. Don't worry, we can manage easily. We can manage. Even I can take a class on this. We can use some amount of positive pressure and steroid therapy. It is very nicely we can manage this. Very easily manageable. People will not die because of airway edema. People will die because of not able to manage other causes. I will tell this. If the patient ready to wean, most other patients are weanable. When weaning fails, this come to the word called difficult to wean. In the difficult to weaning, how now there is I want to mention this slide also. Difficult weaning. This is the one I want to mention here. Easy weaning. If you're trying SBT, first attempt you are able to extubate. That's called easy weaning. No need of tracheostomy. Negligible risk of tracheostomy is there. If the patient having failed first SBT and you are trying SBT 3 times or at least 7 days, there comes the word called difficult weaning. You have to tell your physician or whoever surgeon want to tell, sir, it is a difficult weaning. What is the worry? What? Let us pull out the tube. Sir, it is having risk of 11 to 14% mortality. Now recent evidence is more than that. 15% mortality is there. Patient will die because of your extubation, and tracheostomy risk is high. If it is more than 7 days, it is called prolonged weaning. Prolonged weaning, most of the patient will die. So we are talking about death just because of weaning per se. If you are able to convince this to your doctor or intensive, whoever it may be, then they will appreciate. Show them this is a new evidence is there. SBT failed more than 70. I think Sundaram tried more than 7 days, still not able to try. Some anesthesiologist coming on putting on TPs. No, you have to identify why you are not able to wean. Remember this, Bahatit, this is the one which will tell you when to wean, when is the difficult. When you enter into difficult to wean, this is called reintubation associated with mortality. Many people what will do, mortality you can see here, percentage 17, 14, many patients, according to 20 patient have some study of 23%, there is a variation is there. Weaning failure, most commonly airway edema, easily you can manageable, but if it is because of the respiratory problem, most common is COPD, weaning failure happens, and next common is neurological patient. In this case, there is a neurological point is there. Another acute respiratory, most common causes, most neglected part I'm going to tell here. Many people extubate to NIV. So just extubate to NIV, what happens? This is the most dangerous thing actually. So we cannot extubate to NIV on the patient. Yes, NIV helps in weaning only in COPD patients, cardiogenic pulmonary edema patients. There is a criteria, you have to adopt the evidence-based medicine where NIV works. NIV, all extubating NIV, like OP poisoning. I think this patient, if you extubate to NIV on day 6, day 7, because he is not tolerating weaning, he will die, increase the mortality. General ICU weaning, we cannot use NIV patient, NIV at all. When to wean in IV, that's a very important point. So I'm telling you, weaning is a art. You should know when to wean. If you want to wean, can I wean and extubate to NIV? If you want to use non-invasive ventilation, there are three criteria should be adopted. One is COPD. You can use, definitely you can use. Even there is a, legally you are right if you use NIV in COPD patients. That is the standard of care I'm talking. See, these are the criteria, even though mentioned later, earlier days, still holds good, still we are practicing. If age is more than 65, if cardiac failure is the cause, cardiogenic pulmonary edema is there, Apache is more than 12, just go for NIV. So this is whenever COPD, cardiogenic pulmonary edema is there, Apache score is high, don't just extubate to face mask, extubate NIV. It works very well. This is called prevention non, the word is come preventive, the word has come now, preventive 2024. See this patient, what happened, I'm going to tell you what happened here. We most of the time we look at the heart, lungs. In that patient aspiration Dr. Sundar was mentioning, but I want you to see the heart also, how to look at the heart. When the moment you do heart echocardiography, LV is normal, cardiologist come, LV is normal, they will tell. That is a wrong. LV is normal on ACM mode. LV function is normal on ACM mode. But what happens in SBT? Who has seen this? I told SBT is a treadmill test. There are a lot of changes happens in the during weaning. I can again explain with the time permits if you ask me any come with the case with the cardiac. But briefly, I want to tell you the moment you put on SBT, there is a increased work of breathing, adrenaline crisis, increased intrathoracic pressure, RV dilatation will happen. That can cause even LV afterload increases, then can cause weaning induced pulmonary edema. Something called VPO. The word is called VPO. Weaning induced pulmonary edema means while weaning the patient, okay, I can even explain how it works with the pressure values. Okay, this is called heart-lung interaction. This big topic in critical care, heart-lung interaction. Beautiful topic. If you understand heart-lung interaction, we can manage any patient. I will take a class on that. If you are interested, I will do that class also. What happens in full support is there. Okay, the what you are talking about intrathoracic pleural pressure is positive. When you put on spontaneous breathing, patient triggering, that pleural pressure become negative. This negative pressure is not allowing to LV to contract. So LV is working more and more, afterload is increasing. That causes ischemia of the LV and causes LV failure, causes weaning induced pulmonary edema. I know you are not able to understand this. I can show the diagram and thing and explain this part. Very interesting. This is called VPO, new terminology. Remember this, weaning induced pulmonary edema. So here it is only, it is there. Very good. Usually atmospheric pressure is 0, extrathoracic. You look at this is a left ventricle, it's a pleural pressure. Intrapleural pressure is, minus 10. Okay. Left ventricular pressure is 90. Okay. That is something called transmural pressure. What we call transmural pressure means pressure between two domains, I can say, two compartment, I can say. So here 90 is the left ventricular pressure and here minus 10 is there. So 90 minus of minus 10 become 100. So actually afterload is increasing. If you put on ventilator and PEEP of 10, if you put on PEEP of 10, this minus 10 in pleural pressure become plus 10. Then become 90 minus of plus 10 becomes 80. Afterload decreases. So ventilation, PEEP reduces afterload. This is how the PEEP reduces afterload. Without giving diuretics, by using PEEP, you can reduce afterload. That is the beauty of ventilation. So PEEP can reduce afterload very easily. I can explain this. Remember this one. So what happens in this patient? This is called weaning into pulmonary edema. Most neglected part. What are you people should see is you can there is now technology now something called BNP driven fluid. If you have bedside, SOB profile, anti pro BNP, if you're able to do it anti pro BNP or BNP before weaning and do it after weaning. If BNP is increasing means it is a cardiac ischemia. So what you have to do, give diuretic, then again try to wean. Optimize fluid and wean, that's it. Then your saturation will not increase or decrease. Along with the neuromuscular, I'm not neglecting neuromuscular. This is also important part. Heart, especially right ventricle. Many people will forget right ventricle. You have to think there is something chamber which is contributing more in weaning is right ventricle. So I want you to concentrate right ventricle. This is the BNP driven strategy. Tracheostomy, when to do tracheostomy? Simply we can say whenever there is weaning delays, if we pay when it require more than 7 days. Example, if the patient requiring head injury, you know that long time is ventilators, you need tubes. Go for tracheostomy day 3, day 4, no worries. In medical patients, you can wait up to 7 days, okay, 8 days, then go for tracheostomy. Okay, if more than 10 days, delay tracheostomy. Don't do that. Early tracheostomy less than 3 days also risky. If the patient go for, imagine SDH patient can come, we know that patient is bad. During SDH operation only people do tracheostomy and come to ICU. That can be done. So it depends on which patient you are talking, tracheostomy. If the brain is the problem, wakening up is the reason, and example, GB syndrome is there, ventilator requirement is longer duration, myasthenia gravis, go for tracheostomy early. Don't worry, 7 days, 5 days, 3 days. Medical patient, go for like pneumonia patient. In this patient, go up to wait for up to 7 days, optimize fluids, optimize neuromuscular weakness, then we can go for tracheostomy. That is the important point I want to tell. This is the important ventilator induced diaphragm dysfunction. So something called ventilator asynchrony is there. This people want to use ventilator and don't want to extubate. That's it. But what is happening during ventilation? Who is monitoring? That monitoring comes with the ventilator asynchrony. So patient ventilator asynchrony you should learn. Again, is one more topic actually. I will tell you how to adjust the flow, how adjust the pressure, adjust the time, trigger and all. Then you can reduce the, why it is important, more asynchrony is there. Imagine acidosis is there, bicarb of in this patient is 10 20 is there. You want to hyperventilate, you want to give, you need more flow like 100 liters per minute. If you give 40 liters per minute, what happens, he will try to get that flow again and again, there will be air hunger. That patient is called flow asynchrony. That patient invariably not able to win because your work up breathing increasing day one only. He is trying to get that same volume, tidal volume 450, 500 tidal volume with the less flow. He will not do well. Asynchrony is also important. Again, I am telling it is an art. I will tell you this part also, discuss this part. This is the autopep in this patient is developing and outcomes. These are the things, simple, the head and bed dilation, sedative infusion interruption, early morning wake up call, spontaneous breathing trials, prophylaxis, thromboembolism, stress ulcer prophylaxis, oral care with rorexidine. These matters a lot in the patient outcome here. And this is what? Sedation. Nowadays we are stopping sedation early. There are a lot of evidence has come. We suggest protocol attempting to minimize sedation now. Okay, 2024 people are even stopping sedation early also. Physical and occupational, what you call weaning aid actually. Therapy, occupational therapy means early mobilize into chair, physiotherapy, okay, chest physio, limb physiotherapy. Chest physio means not like we used to tap like earlier to remove secretion, not like that. It is like a improving muscle power. That's very important. This will create the whole body. It's called whole body rehabilitation. This will invariably improve the weaning outcome. Please make sure stop sedation, mobilize to chair early, and if the patient is not stable, I'm saying, and try to wean. We can wean early. There are n number of studies are coming now, whole body rehabilitation. Even this patient on ventilator, early mobilization. See, this patient on tube, on ventilator is mobilized. But you need, confidence for that. You need staff support, respiratory therapist support for this. Don't do immediately. Just try to put on chair, then try to make him stand in the tube, then make him one or two steps, then mobilize to bed. Again, tomorrow, next day, you try again. It is a continuing process. Second day, you try two, three steps, then we can win. So this is what I want to mention here. Do not delay intubation, long heart interaction I told already. So in this case, what happened, I'm going to tell now. This is the day 12 actually, when they tried, there is acidosis is there. See what happened, this patient they are weaning, day 1 also acidosis may be there, but day 10 while extubation, there acidosis means patient has got, look at the lactate here, lactate is 11.52. There is a sepsis again. So more than 7 days means there is a risk of sepsis will be there. So source control, I means you have to prevent infection. Source control is the another key. Okay, we can read if you want ABC, and that again you can see here lactate is 0.98 is improved. It is a day 13, I think. After what happened in this case, I'm going to tell. Patient was put on TPs day 9, extubated, again reintubated. Why extubated? Because some pressure from the physician or whoever it may be, and reintubation. Reintubation 12-13 mechanism referred to be into 90 to 40 or 48 hours. There is a lower zone patch. Means there is infection is there day 12 or that. So only lactate is gone up. So probably aspiration because extubated, their power is not adequate. So we can avoided this part, would have been taken precaution day 1. Still, it is not easy as we mentioned. There's something, another point in this case is abdomen, something called abdominal compartment syndrome. So look at the abdomen is tight or soft. If the abdomen is tight, that invariably increase the intrathoracic pressures. So ventilation means not only managing lungs, managing the thoracic cavity, managing the abdomen, managing the muscles also, managing the nerves also. So it is the multimodal approach. So probably aspiration is already mentioned. So this I want to tell. NABH qualified indicators, quality indicators say that any patient extubated should not be reintubated for the same reason. This is wrong actually. Any patient extubated can be reintubated. Say if you extubate any patient in your ICU, okay, how I know that in any ICU they are doing correct weaning or early weaning or prolonged weaning? So there should not be premature weaning so that more and more intubation required. There should not be delayed weaning so that there won't be any reintubation. So what they tell, at least 10 to 15% reintubation is ideal, accepted. So you have to try, at least see, unless you know try, you won't get it. But you should see whether the patient is okay to extubate or not. Okay, you have to look at those criteria what I mentioned. But if you don't try only, patient will be aram on ventilator, there is a neuromuscular weakness will be there, and he will be go for infection and die. So early weaning also dangerous, delayed weaning also dangerous, optimal weaning thing. This is wrong actually. Any base qualified indicator say any patient extubator should be reintubated. No, you can reintubate, but avoid reintubation before only because there are so many criteria are mentioning that you cannot extubate this patient. In such scenario, safety go ahead. Yes, you can go for tracheostomy. Tracheostomy, ideally, I told you 7 days, 6 days. You know that patient is lethargic, not able to have good muscle power. Go for early weaning. Go ahead with extubation or NIV. Don't try NIV. I'm telling you. NIV you should tell only with the 3 condications. So that's the I think class actually. Even weaning had some slides because time. I want to take your questions and discuss. Any questions is there? Please discuss. No, if you discuss only, I can I can come to know what exactly the okay metabolic plus respiratory acidosis. Somebody has mentioned Salman. Correct actually. SIM have become obsolete. No, SIME for the weaning is obsolete, not for the primary. Primary Mode, any mode you can use. SME volume control, pressure control. Inconsistent neuromuscular function, physiological. What is this? Inconsistent neuromuscular function, physiological. I'm not getting this. VAP. Yes, risk of VAP will be there. Correct. Sundaram microphone. Okay. Oh, am I audible? No, you want to understand? I think any issues was there. Okay. So, any doubts? Shikil Pal, Richard, Salman, Sundaram. Any doubt, Shikil?
Sir, I'm just thinking about the patient in case of difficult weaning,
Hmm.
like how to sort out this thing,
Okay.
which I'm not getting.
Yeah, yeah, very good. This one actually. Okay, I will discuss the difficult. Can you see the slide?
Yes, yes, yes.
See, if
It's
difficult.
not completely readable, but yes,
No, no,
yeah, I
no,
can
no.
see.
Don't read this. I'm
Mm-hmm.
telling n number of causes are there. If the SBT fail means you have to think from top
Mm-hmm.
to bottom. Look at the brain. Either any bleed is there, stroke is there. Okay.
Mm-hmm.
Look at the heart. Look at the lung, pneumonia. Look at the abdomen pressures. Look at the muscles, nerves. Look at the electrolytes, actually hypokalemia, hyperkalemia. Look at the calcium,
Mm-hmm.
magnesium, phosphate. Look at thyroid, hormones. Okay. So there is n number of lists. There is some protocol is you have to mention. Okay. I will mention here. See, difficult weaning. There is the most common cause is COPD, neuro, or respiratory failure that I mentioned here. Okay, don't worry about this.
Yes.
Meaning in neurology is very difficult, as in this case also some neurology. This is the heart. Many people neglect this heart. Again and again I'm mentioning. I will discuss this part again because time is not permitting to discuss in detail actually. I can
Yes,
discuss
sir. Which you says about heart and lung interaction,
heart.
which
Yeah.
need to be discussed. Yeah.
Reason for failure. This is very important. I told no, look at the brain first. Are you giving more sedation? Are the patient is sleeping more?
Mm-hmm.
Are there any CNS pathology, stroke, okay, ICH or encephalopathy, delirium? Those patients will be renal failure will be there. You have to look at the condition why that problem is there. Persistent gas section abnormality, weak mismatch. Is there any pneumonia? Is there? You cannot able to see pneumonia in X-ray. Look at CT scan and see whether
Mm-hmm.
there is a hidden pneumonia or abscess is there. Most of the time occult abscess pneumonia patient will not resolving. Look at CT, there is
Mm-hmm.
occult abscess will be there. You have to drain. Whenever a source of infection is there, without draining you cannot do anything for the patients. Persistent pump failure, heart failure, cardiologist come and say that LV is normal, LV is normal. No, we want RV also, right ventricle. We want to know the what happens during SBT also, NT-proBNP before and after. Persistent load and
Mm-hmm.
respiratory system, tube size is okay, length, humidifiers is okay, poor cardiac results, hydrogenic, overfeeding is less likely. Most of the day ICU patient will be underfeeding will be there, but something called overfeeding syndrome is there. More and more feed, more carbon dioxide build up, and patient have more workload to remove that carbon dioxide, unable to wean. Underfeeding, nutrition is a common problem and it is the most neglected again if you don't able to wean after 7 days. Electrolyte imbalance, magnesium phosphate, nobody will do this. Look at magnesium and not only potassium, look at potassium, magnesium and phosphate. Psychological anxiety and fear. So you have to approach to difficult wean step by step. Okay, these are the from head to bottom. You can see even abdomen you have to look into that. Any abdomen compartment syndrome is there or not, you have to look into that. Along with that, ventilator asynchrony I told, no, those things you have to mention. Each is a different topic actually. I can discuss that part.
Mm-hmm.
So you have to look into two direction. Why not able to wean? Why the load is still high? Why lungs and heart not able to manage the load? If you think in that direction, you will come to know the etiology and try to treat that etiology and make sure that load is reduced and able to wean it off. That is the thing. So always think in this direction: neurological, psychological, respiratory load, cardiovascular tolerance, motor functions. So motor function is the, I know, mobilization, ambulation, physiotherapy. Okay, driving.
Physiotherapy.
Look at the neurology. Brain will neglect it. Only we think of lung. No, comes brain comes first to properly manage lungs. CVA, non-convulsive seizures. Seizures are the one of the things patient will be unconscious most of the time. Electrolyte, low sodium, medications, hypothyroidism, sedation, wake up call. I'll try again and again. This is the I'm telling you, 2000, not even 2000, 1997, I think study has come. Still holds good for the wake up trial. Okay, respiratory load. If sepsis is there, load is more, you cannot wean. Fever is there, overfeeding is there. Nutrition support, I told mentioned. Nutrition we can discuss anytime. Support. Look, optimize the nutrition. Cardiac reserve, motor function, say hypophosphatemia, something called refeeding
Mhm.
syndrome. The patient will be
Yes, repeat
taken
please.
food
Mhm.
long time. Patient come to ICU. You know, because of chronic alcoholism, only taking drinks and not feeding. And come to ICU. The moment come to ICU, intubate, ventilate, and start raise tube and foot. Feeding starts, and patient will die.
Hmm.
Feeding causing death. Have you
Ah,
seen
dogo.
this? This is called refeeding syndrome. Means when
Mhm.
there is a
Basta
when
tinha dogo.
patient is not fed, especially some community, they won't take feeding for the 1 month and all. If any case critical illness comes and ventilate comes and ICU and intubate the patient and start feeding, there is a sudden surge of the sudden variation. Excuse me, somebody. Huh. In that case, what happens? No, there is a suddenly potassium goes inside the cell, causes hypokalemia and hypomagnesemia. That can causes cardiac arrhythmias and arrest. This is called refeeding syndrome. So look at this hypophosphatemia. Electrolytes management is basically it is a respiratory alkalosis. These are the things. Ventilation, I'll take a separate class for you. If you are see if you are interested, I can do classes. If you come up with the case.
यस सर सर एक चीज और पूछनी थी आपने कहा कि सिडेशन शुड नॉट बी कंटिन्यू मोर देन 24 आवर्स
No,
राइट
no, no, I
इससे
didn't tell
ज्यादा
like that. No, I didn't tell like that. What I told is try to reduce sedation early. Okay, it's not the timing. Imagine
सर
in
सर
ICU.
रिड्यूशन मींस टैपरिंग द sedation or stopping a sedation I don't
Okay,
get it properly.
okay, if the patient is on ventilator first day, okay,
Mhm,
pneumonia is there. In this case, you're giving fentanyl 50 mg per hour, midazolam 1 or 2 mg per
mhm,
hour. You are giving for 24
mhm.
hours. You given good because you want to manage the pathology.
Yes.
Morning, you have to stop the sedation, see the patient is waking up or not. Because patient is in renal failure, liver failure, there is sedation overload happens. Till the patient wake up, don't give sedation. That is called wake up call. That is called sedation
Okay.
protocol. If the patient become delirious and restart, and make sure the requirement will be 2 mg becoming zero point 0.1 mg or zero point 0.5 mg per hour. Requirement will be reduced because already some load is there. You're getting my point.
Oh,
Third day,
yeah, I'm getting your point.
make sure patient is okay or not. Relaxant you are stopping day for 24 hours. After 24 don't need actually. In ARDS max 48 70 hours is okay. After 3 days, third day, see whether really patient requires sedation, able to manage without sedation only. If the patient is really anxious, is there, use sedation. Intermittent, we can use sedation. Okay. What
Mhm.
it means, it is not if somebody tells something, doesn't mean you can take that patient, that word, and manage all the patient like that. Not like that. Each patient, if you see 100 patients, 100 patients are different. You see, that is the individualization of the patient. Whatever a standard of care is there, it is for guiding you, not to tell you that do the same thing for all patient. It never happens. Nothing called 24 hours. Relaxant also. If you try to manage the relaxant in ERDS 24 hours, 48 hours, then stop it and see what happens. If the patient doesn't require relaxant, no need. If the patient go for prowling, you need relaxant only 7 days, 14 days. 7 days, 14 days, sometimes 21 days, patient require relaxant in patient of prown ventilation. You are getting this point, no? Each patient is different.
Yeah, I am getting it. Yes.
Okay.
Each patient requirement is different. Just we need to analyze according to the
Uh,
situation.
Stop early morning
Mhm.
sedation when you come to ICU and see really required or not. Okay. Okay, I think 8:15. Any more questions are there?
No, sir.
Sundaram, thank you for the case. If anything, any difficulties while managing, very happy to discuss. At least you can learn one by one points. Each patient different. Even sometimes I'm not able to answer each and every because I've not seen the patient. Maybe something else is there, but at least you can take these concept and apply the patient next patient. Each day is learning, then you can manage the patient. So if next anybody want to present, please present the case. Shikpal, you can present. Shikil Pal, right? Dr. Shikil
Yes,
Pal
sir.
from
Shakil
South
Bhai, sir.
Africa or South America.
South Africa, sir.
Salman from which place actually? Salman Hussein. Okay. Salman. Okay. Sundaram from Chennai. Okay. Richard is here only. Okay.
From Kolkata.
Kolkata. Very good. Okay. Yeah, Salman, any doubts you have?
I have a doubt, sir. Sir, why SIMB totally obsolete now?
See, in that study, I told no that brochure study, where they tried SIME process support, reducing rate they tried. See, usually we keep the rate of 12 to 14 rate will keep, okay, for CSI press support. Then weaning, as a weaning only it is obsolete, not for the primary mode. See, SIM is volume control mode, anytime you can use it, daily you can use it. What you are talking about weaning aspect, don't use SIME press support mode. But other than that, better mode is CPAP press support mode or TP trial. Okay.
Okay.
In that trial, well, started reducing the rate from 10 to 8, 8 to 6, and 6 to 4, and telling the patient to breathe more and more. That was the thing they did. It failed. That horribly failed, and patient not able to win with that mode. So don't use it. When you know that evidence is telling don't win, don't use it. SIME as a primary mode, anytime you can use it. Don't worry. Primary mode means the patient comes to ICU, you want to intubate, ventilate, you want to select the mode, you can select volume control mode, pressure control mode, like that. You can select SIME mode. SIME is not a basic mode. You can use either SIME volume control or SIME pressure control mode.
Okay. Okay, sir.
Any,
Thank you.
okay. Okay. Any, if there is no case, Richard, beautiful concept methodically explained. Oh, good. Richard, if you're able to understand, very happy for that. Critical care is powerful, inspired to learn more. Great. Come up with the cases, we'll discuss. Tomorrow, next time, we'll discuss about the asynchrony also. So, how to optimize asynchrony also. And tell your friends to come for the class. Okay. Thank you. Thank you. Thank you. Bye.
Thank
Bye.
you, sir.
Thank you. Bye. Bye. I'm stopping.
Thank you, sir. Mm.